Welcome back, everyone. This is Dr. Giuliano, and today we are going to be talking about our last topic in the video series, obsessive compulsive disorder, or as we'll refer to it, OCD. It usually begins early on in life. 20% of people that develop OCD will develop by childhood, 29% by adolescence, and about half by the age of 20. The onset of illness is going to be a little bit earlier in men and women, and it's a very chronic and debilitating disorder. There is some genetic component. There's 11 to 12% risk of developing OCD if a first-degree relative has OCD. Up to 50% of OCD patients do have comorbid psychiatric disorders, and this is usually depression. Generally, it takes a good amount of time before they seek help, 7.5 years, which is quite a long time, and 20 to 40% of these patients also have involuntary movements. Some overlap with Tourette's syndrome. So both serotonin and dopamine have been implicated in the pathogenesis of OCD. There have been some imaging studies that indicate OCD patients show hyperactivity in the ventral prefrontal cortex of the brain. This is related to a loss of inhibitory processes, and this results in increased metabolic rates and difficulties in inhibiting thoughts and rituals that we would inhibit on a day-to-day basis. It's characterized by the presence of recurring and distressing thoughts, impulses, or images. These are going to be the obsessions, and then repetitive behaviors or mental acts. And these are going to be the compulsions. Usually the compulsions are done to get rid of those obsessive thoughts. Patients may be secretive about symptoms, and they may refuse or deny that they actually have them. And this sort of goes along with taking so long to actually get this disease diagnosed. So the DSM-4 criteria needs to have the following two things: both the presence of obsession and or compulsions that are severe enough to cause marked distress, to be time-consuming, that has to occupy more than an hour a day, and to cause significant impairment in social and occupational functioning. And it can't be due to, like our other anxiety disorders, it can't be due to other medications, mental disorders, or health conditions. Now, there are some specifiers with OCD. There is how well they really understand if their obsessions are true or not, and if they believe they are true or not. And they might have good insight. They might understand that their obsessions may not be relative to the real world. They might have poor, or they may be delusional, and they may think that their obsessions are real. And then tic-related, if the patient has a tic disorder. Now, obsessions, which can again be suppressed by the individual repeatedly performing compulsions. These are going to be repetitive thoughts, images, or impulses, and those compulsions being those repetitive behaviors, mental acts. And they're really going to be done to reduce the distress to the patient. Here's some screening questions that you might ask someone. Do you check things excessively? Do you wash your hands frequently? Do you have repetitive thoughts that make you feel anxious and you can not get rid of? Do you keep things exceptionally clean? Our treatment goals for these patients is not remission. It very rarely occurs, so we're looking at a reduction in symptoms. A failure is considered less than 25% reduction in symptoms versus a response is a 50% reduction. Most successfully treated patients still have residual symptoms that limit their functioning. As far as non-pharmacologic therapy goes, cognitive behavioral therapy is the treatment of choice for mild OCD, and should be offered to every OCD patient. It involves exposure and response prevention therapies, and although CBT is limited by availability, of course. If there's no response to cognitive behavioral therapy, then an SSRI should be added, and combining the two has been shown to be effective. So our pharmacologic treatment is going to center around serotonin for the treatment of OCD. And medications with noradrenergic reuptake inhibition produce no benefit, and they may actually counteract or diminish the efficacy of serotonergic reuptake inhibition. The FDA has approved clomipramine, fluoxetine, fluvoxamine, paroxetine, and sertraline. And as we've been talking about, serotonin is very important for the anti-obsessional effects of the medication. SSRIs are first line. If one SSRI is ineffective, then you should try another one. 65 to 70% of patients will respond, so it has fairly high response rates to the first treatment, and 90% with additional drug trials. Clomipramine may be selected after they have failed 2 to 3 SSRI trials, and can even be used to augment SSRI in partially responsive patients. Symptoms usually improve after a 4 to 10 week treatment period. Venlafaxine has been shown to be effective at smaller doses, but at larger doses you're going to get to more of the noradrenergic effect, and it could even diminish the efficacy at higher doses of the serotonin effect. In general, antidepressants lacking prominent serotonin reuptake inhibition are ineffective in OCD. Adjunctive therapy with risperidone, olanzapine, quetiapine, haloperidol, and aripiprazole have shown positive outcomes compared to placebo in treatment-resistant patients. But we don't know which one would be more effective really than the other. Special considerations for OCD. Clomipramine, fluvoxamine, sertraline, and fluoxetine are all FDA approved in children, and SSRIs are going to be first-line agents. An elderly limitation is available, but as far as drug levels go, paroxetine and sertraline have shown higher levels. Paroxetine may be associated with more anticholinergic side effects, so it may not be the best choice for elderly patients. The selection really should be based off the patient and the side effects and the drug interactions, and go from there in choosing the best agent. Pregnancy, cognitive behavioral therapy can be used alone for patients where treatment outweighs risks. OCD may worsen during pregnancy and during the postpartum period. If drug therapy is selected, fluoxetine appears to be the safest choice, but you really should avoid TCAs in pregnancy. So here's our treatment algorithm. We'll start at the top. We are going to use an SSRI. We look for reduced symptoms. If we do, we continue treatment. If not, we are going to switch to another SSRI. And remember, we're going to treat these patients usually for a very long time, because this isn't something that's going to go away. You can switch to another SSRI after 2 to 3 are tried, then we can switch to clomipramine. And then if we're still having issues with response, there are some other routes we can take. If we're having inadequate clomipramine response, we could try adding buspirone. If they have tics or psychosis, we could consider adding antipsychotic therapy. If they have anxiety or agitation, we could add clonazepam. And again, inadequate SSRI response, we could add clomipramine. And eventually, if nothing else is working, we could try a monoamine oxidase inhibitor and go from there. This is a table with all the different drug doses and the various anxiety disorders or other disorders that we talked about. And then at the very end, I did include some of the additional DSM-5 changes with anxiety disorders, specifically the diagnostic criteria of selected mutism and separation anxiety disorder. And just note that these have also been added to OCD, as subcategories: body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation disorder. But I'm not going to go into full details. This is more of just an FYI. Thank you for listening.